Hey Jeff.
Hey, Gil.
All right, so I think I'll just say hi to everyone and introduce you quickly, and then I'll ask Jess to put it in the group chat that's starting. So hey everyone, thanks for walking up to today's revision lecture. It'll be on upper limb, and we've got lovely Jeff here to help run you through it. Um, we're going to be trying something a little bit new today. So for swap back lectures, where I'm gonna leave the meeting and I'm just gonna let the recording go to Jeff and see how it goes. So hopefully we'll have the recording up by Tuesday, or on the MUMUS YouTube channel. And as always, if there are any questions, feel free to send me a message. Also, Jeff, if there's anything with the recording or slides or anything like that, send me a message and I'll help you out.
Mm-hmm.
And just reminder that because it's just a little tip. It says recording in the top left, right? For
Yep.
you? Yep. Okay. All right. Great. All right. Just double checking to make sure we're recording. Okay. Cool. I'd say start maybe at 10:05, and thanks for everything. All right.
All right.
See you
All right.
guys. See you guys later.
See ya. Thanks for the help.
All good.
Yep. So wait till 10:05. All right. Let's get started. So, welcome to the upper limb revision lecture. So let's go through today's goal. It's to understand or appreciate the anatomy of the upper limb conceptually. So anatomy, a lot of it is memorization, but if you can understand it conceptually or appreciate it conceptually a little bit, it'll really help with your understanding. So we'll achieve that through two methods. One is being able to visualize the origins and the insertions. So knowing the specific spots of origin and insertion isn't that important, but being able to visualize whereabouts it kind of is really helps. And understanding why things are named the way they are will really help us be able to appreciate the anatomy conceptually. So this is the outline for today. We'll be spending most of our time talking about the brachial plexus, the muscles of the forearm, and pathology. So basics of anatomy. Whenever we use descriptive language anatomy, we're always referring to the body in the anatomical position. So that's pretty much the body standing with your arms by your side and your palms facing outwards. So that's the default position that we refer to when we use anatomical language. We've got three different aspects which are really important for imaging. Coronal splits the body into a front half and back half. Sagittal splits your body into a left and right, straight down the middle, 50-50. Now there's a plane called the parasagittal plane. So para means next to. So the plane next to the sagittal plane. So the parasagittal plane might split your body into a 40-60 left-right split, for example. And you'll come to know that prefixes and suffixes are really important in medicine. Yeah. And then you get the axial plane, cutting your body into a top half and a bottom half. Now, what do you need to know? You need to know the landmarks of your bones, but we won't be touching on those today. So I think you guys should be pretty familiar with those. There's nothing really difficult about them apart from memorization. Why do we need to know the landmarks? Because muscles and ligaments attach there. Now, I mentioned at the start that origins and insertions really help us understand anatomy conceptually. So you want to know the origins and insertions for the easy muscles. So what are easy and hard muscles? Well, easy muscles are muscles with really well-defined origins and insertions. So for example, the infraspinatus comes from the infraspinatus fossa and it inserts into your greater tubercle. So really defined origins and insertions. Whereas a hard muscle is a muscle with complex origins. So for example, your pec major, right? You know, there's muscles coming from the clavicle, from the sternum, from your ribs. You don't need to memorize what ribs they come from or whatever. Just know the general region where these complex muscles arise. But the pec major then inserts into your bicipital groove. So why do we even study the origins and insertions? Why do I emphasize it so much? Because it can really help us determine the movement of the muscle. So for example, the pec major, it starts in your chest, right? In your sternum, clavicle, whatever. It attaches into your bicipital groove in the default anatomical position. The bicipital groove is sort of on the anterior surface of the humerus. So if you imagine those two dots, right, the muscle contracting pulls those two dots closer together. So the origin and insertion closer together. So what action is going to be mediated? You're going to get internal rotation of the humerus and also a little bit of adduction. So essentially, if you know the origins and insertions, you can very accurately tell what action the muscle is going to do. And as you'll find out in the forearm, that's really helpful. You also need to know the innervation of the muscles, which isn't too bad because there's always a general pattern, especially in the upper limb. For nerves, the pathway is helpful to know. It's helpful to know. And you need to know some branches. So only the clinically relevant branches. For example, the median nerve has this palmar sensory branch, and that's clinically important in the carpal tunnel syndrome. So we'll touch on that later on. Same thing for your vasculature. So your arteries and your veins. Pathway, kind of important, but you need to know the clinically relevant branches, like your profunda brachii and your posterior circumhumeral circumflex artery. And pathology is important. So pathology is stuff like fractures, diseases, whatever, injuries. And also, my mic's pretty dodgy sometimes, so if it like fizzes out or something, just let me know in the chat. These are the bones of the upper limb. We're not going to touch on it that much. I think you guys should know it pretty well, or have a general idea of the bony landmarks. So vasculature, just going to do a quick run through. Your upper limb is supplied by primarily by the subclavian artery. So you have a left and right subclavian artery. They both come off the aorta in a different way. So blood gets pumped by your heart into the aorta. Some enter into the left subclavian artery directly, whereas some go into the brachiocephalic trunk. So brachio means arm, and cephalic, you'll come to know, means head. And it makes sense because this artery here goes to the head, the common carotid, but you don't need to know about that. So brachiocephalic, arm, head, trunk. Then you get the subclavian artery. Why is it called a subclavian artery? Because sub, behind, the clavicle, clavian, so subclavian artery. And that helps you remember when the subclavian artery becomes known as the axillary artery. Because as soon as it traverses the clavicle, the name changes. And the first rib's pretty closely associated with the clavicle. So first rib, clavicle, kind of the same thing. Well, they're not the same thing, but conceptually anyway. So after the subclavian artery, you have your axillary artery. So axillary means armpit. So this is the region of the This is the artery in the armpit. And the border is the first rib and the inferior margin of the teres major. I don't really have a tip for remembering the teres major, so yeah, just remember it. Then you become the brachial artery. So brachial, as I said before, means arm. So once you enter the arm, you become the brachial artery. You have two important branches here, the profunda brachii and the posterior circumflex. So we'll talk more about that in a sec. Your brachial artery bifurcates into the radial and ulnar artery in the cubital fossa. The radial and ulnar artery then come to form your palmar arches, which is, if you want to go study it, you can, but it's not that, it's like low yield. The important thing is they form an anastomotic connection. So your superficial and your deep, your radial and your ulnar, they form an anastomotic connection. What does that mean? Well, it means you have multiple arteries, or you have multiple arteries coming together. So we have our radial and ulnar coming together to form an anastomotic connection, or also known as collateral circulation. The two branches that I mentioned before, the profunda brachii and the posterior circumflex, these are the high yield points. Profunda brachii runs with the radial nerve in the radial groove, which means it's vulnerable to a mid-shaft fracture. And the posterior circumflex loops to the posterior of our body through this space to innervate the shoulder muscles. We'll talk more about the quadrangular space in a sec. Now veins, they're also pretty low yield, but it's good to study. There's two compartments to it. There's a superficial and a deep compartment. The superficial arrives from the dorsum of your hand, so the back of your hand. You have two veins here, basilic and cephalic. They rise up your arm, then they dive deep into your arm and join with the axillary vein, sorry. Now the axillary vein is part of the deep venous system in your arm. And they come from your palmar veins deep in your hand. And they eventually become the axillary vein, joining with the superficial branches. Then your axillary vein drains into your superior vena cava, into your heart. Then your heart refreshes the blood with oxygen, gets pumped back out again. So yeah, so someone just asked, should we know the course of these veins? They're not that important as compared to like pathology or the forearm muscles. So I would only study those if I've studied everything else. I hope that helps. Okay, now we'll talk about the spaces. So yeah, feel free to ask any questions as I talk. So we've got a few spaces here in the upper limb. First, the quadrangular space, which I've marked out here with my sparkly pen. We've got two important vessels traveling through here. Okay, we've got the posterior circumflex artery and the axillary nerve. So how do I sort of remember this? Well, I remember the vessels that travel through the quadrangular space are the vessels that sort of loop around, okay? So both the posterior circumflex artery and axillary nerve, they start sort of in the anterior of our body. They have to go to the posterior of our body to supply the shoulder and surrounding structures. So they travel through the quadrangular space to reach the posterior of our body. And there's a space also called the triangular space, which also has vessels going through it. But the vessels going through here are the ones that sort of loop, okay? So axillary loops a little bit, and posterior circumflex also loops a little bit. And these are the borders. Then we have the triangular interval, okay? So that's just below the quadrangular space. And the important structures traveling through here are your profunda brachii artery and your radial nerve. Now these are packaged together, so it's really nice that they both go through the triangular interval because they both run together in their radial groove. So these two structures also need to go from the anterior of our body to the posterior of our body because, as you might know, the radial nerve supplies the entire posterior compartment of our upper limb. So it has to reach the posterior somehow. So that's the triangular interval. The cubital fossa, just a few important things is that the brachial artery bifurcates here and your median nerve runs here. And some sources say the radial nerve. And know the borders of the cubital fossa. I think they ask questions on the borders. Then we have the carpal tunnel, which is another space. We'll talk more about this in the pathology section when we come to carpal tunnel syndrome. The important thing to know is that the median nerve runs under the flexor retinaculum, which is what forms the tunnel, closes off the tunnel. And another important thing to know is that the ulnar nerve and artery don't run in the carpal tunnel, they run above it in a separate canal called Garland's canal, which can also be compressed, but we'll talk about that in pathology. Finally, the anatomical snuffbox. The borders are pretty important to know. And the key high yield points here is that the radial artery runs in here. So you can palpate your pulse if you sort of put your finger there. And the floor, so what forms the floor of this space is the scaphoid and the trapezium. Okay, so now the brachial plexus, which is a pretty daunting subject. Hopefully I'll try and make it a bit conceptual. So what does the word brachial plexus mean? As we said before, brachial means arm, and plexus means a network of vessels. So in this case, it's a network of nerves. And we have multiple plexuses throughout our body. So we also have a sacral plexus down near our pelvis. That's just another example. Now, the brachial plexus has both sensory and motor functions, coming from the C5 to T1 spinal, coming off the C5 to T1 spinal cord. And so the brachial plexus is divided into 5 sections, sort of: roots, trunks, divisions, cords, and branches. And here's just a mnemonic. I'm sure you have your own. Right, Rihanna takes down Chris Brown. Okay, now let's talk about the first part of the brachial plexus, the roots. Now, the roots aren't really that important so the roots aren't as important as some other sections. So I'll just go back. It's the cords and the branches that are really important to understand for the brachial plexus. The roots play a lesser role. So I only want to clear up maybe like a potential for misconception here. That's the difference between the roots of the brachial plexus and the roots of the spinal cord. So you might be, when you first study the brachial plexus, you might have Googled about the roots of the brachial plexus. And you read about the roots of the spinal cord as well. You're like, are those two the same thing? They're not. So the roots of the brachial plexus are different from the roots of the spinal cord. And you don't know anything about the spinal cord yet, not the ventral rami or whatever. Just know that the root of the spinal cord is different from the root of the brachial plexus. The root of the brachial plexus is a continuation of this thing over here called the ventral ramus, but you don't need to know that. So this slide is only to clear up any misconceptions. But you do need to know the branches, all the branches of the brachial plexus. And I'm sure you've been to other PSPs where they teach you how to draw the brachial plexus and stuff like that. So I won't do that today, but I'll lead you through conceptually the brachial plexus. So we've got branches here, dorsal scapular nerve coming off, innervating these muscles. Long thoracic formed by C5, C6, C7, innervating the serratus anterior. So there's not much to these. You just go back and learn these, but they're important to know. Now, each root has an associated dermatome. So what's a dermatome? A dermatome is an area of sensation that is associated with a particular spinal cord level. Okay, so an area of sensation associated with a particular spinal cord level. So what that means is anything you sense over here goes back to C5 spinal cord level. And dermatomes are really, really important, especially when you do clean skills of the upper limb. So this is really, really important to know. Myotomes are muscle movements or movements associated with a particular spinal cord level. So C5 does shoulder, ab, and adduction. Myotomes are not as important to know as dermatomes. Next, we'll talk about trunks. They're not that relevant either. Just know that your roots come together to form the trunks. You've got upper trunk formed by C5, C6, lower trunk formed by C8, T1, and middle trunk formed by the C7 root. Here's just a branch. You can go back and study it. I don't have much to say about the branches. So we know that brachial plexus, right, innervates all of the arm, right, brachial. So, but it starts in the spinal cord. So how does it go from the neck to the arm? Well, it travels through the neck muscles, the anterior scalene and the middle scalene. So you don't even know about the neck muscles yet. So you don't even know about the neck muscles yet. But just a general idea is that you have three neck muscles, the three scalene muscles. They're triangular, which is why they're called scalene. You have anterior, middle, and posterior, and your brachial plexus travels out between the anterior and the middle. And the subclavian artery also travels between the anterior and middle scalene muscles. Now, this is important because the cords actually wrap around the anterior scalene, the axillary artery, which we'll touch on that in a sec. Yep, so the cords wrap around the axillary artery. So I've actually circled the branches here. But yeah, the cords are sort of behind the clavicle. And I knew this was the branches because of the characteristic M. So whenever you see the M, you know you're looking at the branches. Kind of looks like a Macca's arch. Okay, the divisions. Now, these aren't really important either. Anterior and posterior of each. You have an anterior and posterior of each trunk. Now, in the adult anatomy, the anterior and posterior aren't really important. They're named anterior and posterior because they're important because they're anterior and posterior when in the developing baby. But in the adult anatomy, they get jumbled around, so they're not that relevant anymore in the adult anatomy, or the naming isn't that relevant to adult anatomy. You have upper, middle, and lower. Now, the important part of the brachial plexus, to know, is the cords. And what's really important to know here is that the cords are named based on how they're arranged around the axillary artery. Okay, so the posterior cord is posterior to the axillary artery. The medial cord is medial to the axillary artery, and the lateral cord is lateral to the axillary artery. And cords are really important to know because they're what give rise to your branches, right? So the nerves that we know, so radial, axillary, etc. These are just some branches. I guess one thing I'll mention here is that the Pec Major has dual innervation. So it's innervated by both the lateral pectoral nerve and the medial pectoral nerve. And it gets innervated by the medial pectoral nerve because it pierces through the Pec Minor to reach the Pec Major. And just some more branches that I won't go through because you can study them yourself. Okay, now, why do I place so much emphasis on the cords? Because, as I said, they give rise to your branches. So the posterior cord gives rise to the nerves that travel in the posterior compartment of your arm, okay? So the radial nerve, right? So the posterior cord gives rise to the radial nerve. And it makes sense because the radial nerve travels posteriorly down your arm to innervate everything in the posterior compartment of your arm. And the axillary nerve comes off because it needs to go to the back through the quadrangular space and loop around to innervate your shoulder muscles. The lateral cord, actually, I'll talk about the medial cord first. Now, we know that down the medial aspect of the arm runs the ulnar nerve, right? So it makes sense that the ulnar nerve comes from the medial cord, and the medial cord is medial to the axillary artery. So it makes sense that the ulnar nerve comes from the medial cord. And the lateral cord innervates the flexes of our arm. You might know that the musculocutaneous nerve, I mean. You might know that this nerve pierces the coracoid brachialis and ends as sensation to the lateral forearm. And it makes sense that it comes from the lateral cord because the musculocutaneous nerve sort of takes a diagonal or an oblique route through your arm, starting from your shoulder to your lateral forearm. So it takes an oblique route, a diagonal route. So it makes sense that it's a lateral cord. We'll look at some photos later. And the median nerve is formed from both the lateral and medial cord, which makes sense because it's between them. Okay, now just on the specific nerves, the axillary nerve, as I said before, innervates the shoulder muscles, deltoid and teres minor specifically. I'll just talk about some notation here. So whenever you see MM, it means plural, so muscles. Whereas if it's just one M, it means muscle. And that's the same thing with AA and A, so arteries versus artery, and veins versus vein. And the axillary nerve ends in the shoulder. So it gives sensation there, right? If it ends there, then it gives sensation there. That's a common pattern. The radial nerve, right, it runs and innervates all of the posterior muscles. Comes from the posterior cord. And it ends in the lateral dorsum of the hand. So it gives sensation there. Now, the actual names of these cutaneous branches, you don't need to know. Just remember, though, where they sort of end up, especially for the hand, right? Which nerves end up where. Yep. So for the musculocutaneous nerve, right, it pierces the coracobrachialis muscle here, and it ends up in the lateral forearm. So you can sort of imagine it taking an oblique route, right, a diagonal route. So it makes sense that it comes from the lateral cord. It does all of your arm flexes and gives sensation of the lateral forearm. Why? Because it ends there. And you can sort of help remember that by remembering that comes from the lateral cord. The median nerve does all of your forearm flexes except these two muscles. Okay, so the Flexocarpi ulnaris, so it's on the ulnar side, and the flexor digitorum profundum, which is deep to this muscle, and it's got dual innervation. So just remember, forearm flexes are all median nerve, apart from the ones on the really medial side, which will be done by the ulnar nerve. And it does some muscles of the hand, specifically the Athena muscles and the first and second lumbricals. And it also ends as sensation over here. So I said before, sensation of the hand, you need to know, this is really important, you need to know which nerve gives sensation to which portions of the hand. The ulnar nerve really, so the median nerve does all the forearm flexes. The ulnar nerve is primarily the hand muscles, with the exception of some flexes over here. So we'll touch on this more when we get to the forearm section. So they do pretty much all the hand muscles, apart from the Athena eminence and the first and second lumbricals. Now, this is just a quick revision. So lateral cord, arm flexes, sensation in arm. Radial nerve travels over the lateral epicondyle and then does everything in the back and so on. You can read this in your own time. Okay, now we'll go on to talk about muscles and movements. We'll start off by talking about the shoulder. So these are the muscles of the shoulder. Let's talk about the anterior compartment first. So we've got Pec Major and Pec Minor. Pec Major overlies the Pec Minor. And we've got two high yield points. The Pec Major has dual innervation because the median pectoral nerve pierces the minor to innervate the major. And we've also got this thing called the lady between the two majors. You guys might have heard of it in your shoots or something. But lady sounds like lat. Okay, I don't know why, but so it's talking about the Latissimus Dorsi. And the two majors are the Pec Major and teres major. So it's talking about the how things are inserted into the bicipital groove. Okay, so that's the bicipital groove. And the Pec Major and teres major come from the back. Okay, and they sort of travel through your armpit and insert into your bicipital groove. So you can kind of imagine that if the teres major and lats contract, they'll internally rotate your arm. Yep. Next, Serratus Anterior. There's three important points about this. One, it's innervated by the long thoracic nerve, which comes off the roots of the brachial plexus. And clinically relevant to that is the winging of the scapula. We'll talk about that in the pathology section. And third point is that it's responsible for abduction, shoulder abduction above 90 degrees, which makes sense because if you want to abduct your shoulder greater than 90 degrees, your scapulars, your shoulder blade is going to need to move. So your serratus anterior is attached to the shoulder blade, your scapula. Third muscle, subclavius, not that important. Just the name, subclavius, below the clavicle. So sub means below or behind. Okay, now the rotator cuff muscles. We've got 4, right? Everyone has their own way of remembering them. So sits is pretty common. I like to use S-sit, right? It's not really anything, but why do I do this? Because it helps me remember how they attach onto the humerus. So S stands for subscapularis, and it's the only muscle that attaches to the lesser tubercle. Okay, so there's the subscapularis there, and there's the lesser tubercle there. So because we know the general area of origin and insertion, that means we also know the action then. Because if you imagine this muscle contracting, i.e. bringing these 2 points closer together, what action is going to be mediated? Well, it's going to be internal rotation. Now the other 3 rotator cuff muscles all come from the back. They're the supra and infraspinatus and the teres minor. And that's the order they insert onto the greater tubercle. So supraspinatus, infraspinatus, and then teres minor is the last one. Some high-yield facts. Supraspinatus is responsible for abduction to the first 15 degrees. So if you imagine this muscle contracting, you can imagine it pulling the humerus up, abducting the humerus. And teres minor is superior to the teres major. Now, I just put it here to help you remember that it's above the teres major. There's nothing really clinically relevant to that though. Okay, now we'll talk about the posterior muscles. So we've talked about the rotator cuff, right? The 3 posterior rotator cuff muscles, right? Supra, infraspinatus, and the teres minor. We've got our levator scapulae and rhomboids. These are innervated by the dorsal scapular nerve, I think, from the brachial plexus. Deltoid, important fact, it's got 3 heads, and the middle head does abduction up to 90 degrees. So I think this is supposed to be teres major, so I'll change that in the slides after. And lats, so the 2 majors insert into your bicipital groove. So remember the lady between the 2 majors. And lats innervated by a branch of the brachial plexus. Okay, movements of the shoulder. So what muscles are responsible for what movements? Abduction is a summary. So supraspinatus does the first 15 degrees, assisted by the middle deltoid. Then the middle deltoid does the rest, up to 90 degrees. Then the serratus anterior does from 90 to 180, assisted by the tracts. Adduction is the Pec Major. If you think about the origin and insertion, that will make sense to you. So Pec Major inserts into the bicipital groove, and we know that because of the lady between the 2 majors. They all insert into the bicipital groove. And you can sort of guess where the Pec Major, where the origin is, right? Somewhere like in the chest area, near your sternum. So if that contracts, it's going to be adduction. Flexion is the anterior head of the deltoid. You can kind of imagine that. Extension is posterior deltoid. You can also kind of imagine that. Internal rotation. So I mentioned before how the subscapularis mediates internal rotation. Now, external rotation, right? So the infraspinatus and teres minor come from the back, right? The posterior scapula. Yeah, so they come from the back and they insert into your greater tubercle. So let me get an image. Yeah, so here's a teres minor, here's an infraspinatus. They insert into your greater tubercle over here. So you can imagine that if this contracts, if these muscles contract, they're going to externally rotate your arm. And here's just the rotator cuff muscles highlighted. And here's the, just to remind you of where the teres major inserts into the bicipital groove to help you remember that it's responsible for internal rotation. Now we'll talk about the arm. So we've got a few flexors, one extensor. First, let's touch on the biceps brachii. The important facts are that the long head tendon runs in the bicipital groove, and that the biceps brachii is actually a really powerful supinator, right? Rather than a flexor. And if you think about the origins and insertion of the biceps brachii, that'll make sense. So it originates from the coracoid process and like the bicipital groove, somewhere around there. And it inserts into some tuberosity on your radius. Right? I forgot the name, but I think you guys would know. So you can imagine if it runs from your shoulder to somewhere on your radius, you can imagine if it contracts, it's going to pull your arm. It's going to supinate your forearm. And an easy way to remember supinate is you want more soup, so that's supinate. And because of the origin insertion, it should be clear that the biceps brachii actually doesn't touch the humerus, right? It crosses over the entire humerus. The coracobrachialis, there's not much interesting about it, apart from the fact that it's pierced by the musculocutaneous nerve. And here you can see the oblique pathway of the musculocutaneous nerve pretty easily. So again, it comes from the lateral cord. Then we have the brachialis, which is the most powerful flexor. The musculocutaneous nerve runs above it. So it pierces through that, then runs above it. And it's responsible primarily for, like you see bodybuilders with these big biceps. Well, the size in your biceps is primarily due to your size of your brachialis. So if you want to get big biceps, you don't do bicep curls, you do hammer curls, which target the brachialis more. Then you have the brachioradialis, which brachio, arm, radialis, radius. So it's more of a forearm bone, but it starts in the humerus. And it's kind of unique in that it's a flexor that's innervated by the radial nerve. Whereas all the other flexors are innervated by the musculocutaneous. So just remember this, I guess. Then for the extensors, you have your triceps, done by the radial nerve. Now there's some debate in medical literature over what heads are innervated by what nerve specifically, but for our purposes, the radial nerve is good enough. Arm movements, all four flexors do flexion, right? Primarily brachialis, and the triceps does extension. If you think about origin insertions, it makes sense. So now onto the forearm, which is like the worst part of the upper limb. Now, looking at this list, it's pretty intimidating. So what do we do to help us learn the forearm? We don't need to memorize all the actions because, but what do we need to know? So one thing you definitely need to know is what compartments each muscle is in. But studying the forearm is really made a lot easier if we understand first where they originate and where they insert. Now, origin is really easy because lots are shared, right? It's either medial epicondyle or lateral epicondyle. Insertion is, you don't need to memorize it because it's pretty easy to tell what the insertion is just from the name. So for example, the Flexocarpi ulnaris, right? Carpi means wrist. So you flex the wrist on the ulnar side. Okay, you flex the wrist on the ulnar side. So it's likely going to insert into your medial carpal bones. Specifically, it inserts into your pisiform. And you'll find that a lot of these insertions, you can sort of tell where they insert just from the name of the muscle. And why do we need to know the origin and insertion? I'll just emphasize again that it tells you the action. So important point here is understand the names. Okay, let's go through the anterior forearm. So we've got 3 compartments: superficial, intermediate, and deep. These are the number of muscles in them. The muscles of the anterior forearm, they're the flexors, and they're all innervated by the median nerve, except the muscles on the medial side, right, on the ulnar nerve side. So they're done by the ulnar nerve. Okay, the superficial compartment has 4 muscles. We've got pronator teres. We know they all originate from the medial epicondyle. So if it originates from the medial epicondyle and it's a pronator, where does it have to insert to pronate? Well, it starts from the medial epicondyle. If it wants to pronate the arm, it needs to insert into the midshaft of the radius. Because if you can imagine, the muscle contracts, it would sort of rotate. It would bring the radius over. It would rotate the radius, aka pronate the radius. Next, we have the Flexocarpi Radialis. So a flexor of the wrist on the radial side. So it makes sense that it goes to the radius bone or the radial side. And because it flexes the wrist, it will insert somewhere near your metacarpals. Okay, so you don't need to know the specifics, but here I just put it here. I just put them here. But know that it inserts into your carpal, your wrist, your hand, your wrist on your radial side. Same thing with your flexor carpi ulnaris. It's a flexor, so it starts in your medial epicondyle. It flexes the wrist on the ulnar side, so it makes sense that it would attach somewhere on your medial hand. So your pisiform, the ulnar side. And finally, the Polymerase Longus. Polymerase means palm, so use that to remember that it is continuous with the flexor retinaculum, and it's a longus. So if there's a longus, 99% chance there's going to be a brevis. And we'll find out that there is a brevis, Polymerase brevis. And here I'll just highlight where origins and insertions are important again. So we know flexor carpi ulnaris starts from the medial epicondyle, attaches to the ulnar side of the wrist, right? Specifically the pisiform. So what actions does it mediate? Well, first, obviously from the name, it flexes the wrist. Secondly, because we know the origin and insertion, or we know the general idea, the general area where they originate and insert, we can imagine that it also adducts the wrist. So imagine this muscle contracting over here. It will bring your origin, the points. It will bring your insertion point and origin point closer together because the muscle contracts, and that will adduct your wrist. And this is important when we talk about pathology. So just some fun facts. Flexocarpi Radialis. So the radial artery runs between the Flexocarpi Radialis and Polymerase Longus. So if you tense your fist, you might be able to see this tendony structure, right? That's the Polymerase Longus. Now, it's actually absent in 15% of the population, but most people, if you tense your fist, you can see your Polymerase Longus tendon, and just lateral to that will be the radial artery. So if you want to put your finger lateral, if you want to find your radial artery to like count your pulse or something, you can first identify the Polymerase Longus tendon and really easily find where the radial pulse is. Polymerase Longus, the median nerve runs beneath it, which makes sense because the Polymerase Longus, Polymerase, becomes the flexor retinaculum. So the median nerve runs under it in the carpal tunnel. Yeah, and someone just asked me if these slides will be available. So they will be. They'll be on your academic drive. Akil will upload it. And if you can't find it, you can message me. Yep. So the slides in the academic drive are kind of old. Well, they're not updated because I found a few mistakes when I was practicing. So we'll re-upload it. And we have a flexor carpi ulnaris. Okay. Now, the intermediate compartment, there's only one muscle, the flexor of the digits, the superficial version. So if there's a superficialis, there will be a profundus, a deep version, and it flexes your digits. Now, what's important to remember here is that this, right, flexes, it's responsible for flexion of the digits, apart from the distal interphalangeal joint. So we've got 3 phalanges, 1, 2, 3. We've got 2 interphalangeal joints, and we've got a proximal interphalangeal joint and a distal interphalangeal joint. The superficialis only does the proximal one. We'll find out that the profundus does the distal one. So this is high to remember. Superficialis does only the proximal one. Now, the deep compartments, we've got flexor digitorum profundus, okay? So as I mentioned before, that will do your distal interphalangeal joint. And we encounter our first muscle related to the thumb, the pollex, I think. So the flexor pollicis longus. And if there's a longus, there must be a brevis and pronator quadratus. So here there's really no common origins. They come from different things. So these muscles would be what I would call like the complex muscles. So just know the general area where they come from. But it should be pretty easy to remember that the FDP is on the medial side, because if you remember, the ulnar nerve is responsible for some of the FDP. So that means it must be somehow on the medial side, on the ulnar side of the arm. And also know that the pronator quadratus is the deepest muscle in the anterior compartment. Oh, and just another thing, the name of this branch isn't important. I just put it here, but you don't need to know the name of this branch. Now we have the, just more info. So it's the only flexor of the distal interphalangeal joint. You can also do all the other flexion things, all the other flexors. So MCP stands for metacarpal phalangeal joints. So your metacarpal bones are these ones, and your phalangeals are these ones. Yep. And pronator quadratus is the deepest one. Flexor pollicis longus. So we've only got one flexor of the thumb in the anterior compartment, and it's the flexor pollicis longus. And you can sort of, from the name, imagine where it inserts, right? So it flexes the thumb. So you can sort of guess where it inserts. You don't need to know the specific area, just the general area. Now, the posterior compartment, right, it's all done by the radial nerve. We've got superficial and deep compartments. Okay. So superficial all originate from the lateral epicondyle. Now, we've got extensor carpi radialis and extensor carpi ulnaris, right? So we've had flexor carpi radialis and flexor carpi ulnaris before. Now we have extensor carpi radialis and extensor carpi ulnaris. Now, the names should make sense to you now. You've got an extensor of the wrist on the radial side. So from that, you can imagine the course of the muscle. So if it's an extensor, it starts in the lateral epicondyle. If it's a radialis muscle, it must mean it travels on the radial side. So therefore, we can imagine the course of the muscle. And if it extends the wrist, you can sort of imagine where it inserts. And it's got a longus and a brevis. Same thing with extensor carpi ulnaris. And we also have our extensors of our hands, of our fingers, sorry. We've got the digitorum and the digiti minimi. Now they go in the extensor hood. So just some more practice on visualization. So extensor carpi radialis starts from the lateral epicondyle, travels along the radial side. So if you imagine that muscle contracting, it'll abduct your wrist. It'll abduct your wrist, right? Same thing with the extensor carpi ulnaris, it'll adduct your wrist. Now, here we come to the extensor digitorum. The important fact to remember here is that it extends your metacarpals. That's the primary action, right? So it extends your metacarpal phalangeal joint. So metacarpal phalangeal joint. And also it does some interphalangeal extension. So this, right? So interphalangeal joint also extends that. But that's a very minor role of the extensor digitorum. The interphalangeal extension is mainly by the lumbricals. Now that's really important when we talk about the ulnar claw. So just remember, extensor digitorum, metacarpophalangeal joint. So pointing your finger. Then we have the extensor digiti minimi, which name is pretty self-explanatory. And you notice that I didn't mention anything about the anconeus or the brachial radialis because they're not that important, except brachial radialis is a flexor. It's unique in that it's a flexor, but it's on the flexor of the arm, but it's in the posterior compartment. And since it's in the posterior compartment, it's innervated by the radial nerve. Anconeus, like, not that important. Okay, now we've going to the deep levels. We've got a supinator. You can guess what it does from its name. And here we've got the main muscles of the thumb. So let's think about all the actions of the thumb that we know about. We know there's flexion of the thumb, extension of the thumb, abduction and adduction of the thumb. So the four movements of the thumb, right? So we know there's a flexor pollicis longus in the anterior of the forearm, the flexor compartment of the forearm, which makes sense, right? Because it flexes the thumb. The other actions we haven't covered are extension and abduction. And you can sort of guess what compartment those muscles will be in if you think about those actions. So if you extend, so they come in the posterior compartment of your forearm, right? So you have an abductor pollicis longus. So you abduct the thumb, if you look at that action, you can kind of guess that it comes from the posterior compartment of the forearm, and it's superficial to the other deeper muscles, so it's kind of overlies the other deeper muscles. And since it's the longest, does a brevis exist? Yes, it does. Extensor pollicis longus and brevis. Now, how do I keep track what the difference between those two is? Well, longus will be bigger than the brevis, right? Just from the name. So just from the image, you can tell which one's going to be the longest, right? So this one looks a bit longer, so it's going to be the longest. And where does it insert? Well, the brevis is shorter, so it ends earlier in the thumb. The longest is longer, so it goes to all the joints of the thumb. Okay, so brevis doesn't go to the interphalangeal joint. The longest is longer, so it goes to all of the joints. And finally, the extensor indices, also pretty self-explanatory name. Okay, so I hope that helps with the forearm. Now we'll talk about the hand. So the hand's a bit easier. So these are the muscles of the hand. Just know that thenar eminence and the lumbricals some of the lumbricals are done by the median nerve. And remember that the ulnar nerve is the primary nerve of the hand, which innervates the rest of this. So let's talk about the thenar muscles. One action I didn't mention before is opposing. When you oppose, you bring your thumb and your pinky together. So it's done by the opponent's pollicis, and it's the deepest muscle of the thenar eminence. We have an abductor pollicis brevis. So before we had an abductor pollicis longus in the arm. So yeah, then we also have a flexor pollicis brevis. If you remember, we had a flexor pollicis longus before. I don't really have a tip for remembering these names. And these are all innervated by the median nerve. Now for the hypothenar muscles, they're the ones sort of below your pinky, on the other side of the thenar eminence, opposite to the thenar eminence. And the muscles all mirror the thenar muscles. So before we had an opponent's pollicis, so we'll have an opponent's digiti minimi. Before we had an abductor pollicis, so we have an abductor digiti minimi. Same thing with the flexor. Now, I've said a lot that if you have a brevis, you have a longus. If you have a superficialis, you have a profundus. Now, this is one of the only exceptions I know of. There's a flexor digiti minimi brevis, but in humans, there's no flexor digiti minimi longus. That's one of the only exceptions I know of. Now we'll go into some the other muscles of the hand. We have our lumbricals. The lumbricals are the most dorsal muscles of your hand, right? So the ones on the back of your hand. They're even more dorsal than the dorsal interossi. And the lumbricals, they flex your metacarpophalangeal joints and they extend your interphalangeal joints. So before I emphasized how the extensor digitorum primarily extends the metacarpophalangeal. So metacarpophalangeal is primarily extensor digitorum. Extending the interphalangeal is primarily the lumbricals. So this is kind of weird, but the movement of the lumbricals is pretty important to remember because it's related to the ulnar claw. So do what you have to do to remember this. How I remember it is I just make so this is the lumbrical action, so flexing the metacarpophalangeal, and then it extends the interphalangeal. So whenever I want to remember what the lumbricals do, I just go like this. Right, it's kind of weird, but it helps me. And I've got dual innervation. So the median nerve does the lateral two lumbricals, and the ulnar nerve does the medial two lumbricals. The interossi, so inter, between, ossi, the bones. So the between the bones. And you guys probably know pattern that by now. So the palmar ones do AV duction, the dorsal ones do AB duction, and ulnar nerve does all of them. Now these are the other muscles of the hand. First we have the palmaris brevis. If you remember, we had a palmaris longus which is the tendon that you see. And this one also inserts into the flexor retinaculum. It's not that important. Adductor pollicis, it's the deepest muscle when you look at your hand anteriorly. So below the adductor pollicis would be the interossi muscles, right, between the bones. I guess what's important about it is that the radial artery peeks out between the two heads of the muscle. So if you remember, I said that the radial artery was lateral to the palmaris longus. So This is the Polymerase Longus. I recognize that because it becomes a flexor retinaculum, and that's the radial artery. So it loops around, does some things, comes out between the two heads of the adductor pollicis. Now here we have the summary of the courses of the nerves again. So this is just a copy of the slide before in the brachial plexus. Lateral cord, musculocutaneous nerve, right? Because it travels down obliquely through the arm. Ends its sensation in the lateral forearm. Posterior cord, right? So everything that goes to the posterior arm. We have radial nerve and the axillary nerve. Medial cord, right, travels down medially on the arm. So that's why it gives rise to the ulnar nerve. And the ulnar nerve is primarily the hand muscles. And the median nerve is from the convergence, the confluence of the medial and the lateral cord, because it's in the middle. Okay, now we'll talk about pathology. So I sort of separated pathology into fractures, inflammation, and palsies. So first, let's talk about the fractures. We have a clavicular fracture. These are the hyoid points you need to know. The middle third is most commonly fractured, so it's affected the most. And after the fracture, what happens to the clavicle? Well, the lateral end of the clavicle gets pulled down due to the weight of the arm. Now, I'm not sure if you know this, or you might know this, but the arm is pretty much attached solely to the clavicle, right? So the arm is pretty much attached to the rest of the skeleton through the clavicle. Like, it forms the glenohumeral joint with the scapula, right? But the scapula doesn't actually attach to the axial skeleton. So the clavicle is really important then in carrying the weight of the arm. So you can imagine if this is a fracture somewhere along the clavicle, the lateral end will pull down really far. And it will also go in medially because of the Pec Major. And if you remember the origin and insertion of the Pec Major, you'll know why. And the medial end is pulled up by this muscle here, the sternocleidomastoid. So sterno means sternum, cleido means clavicle, mastoid is just a thing on the head. Okay, you don't need to know this muscle. But because of this muscle, the medial end of the clavicle is pulled up. So that's the fracture of the clavicle. Pull down, pull up. Next, we have the fracture of the humerus. Surgical neck, axillary nerve, because it loops around. Mid-shaft is radial nerve. Distal end, so in the cubital fossa, is your median nerve. Then if you injure your medial epicondyle, somehow you get your ulnar nerve, because the ulnar nerve travels under the medial epicondyle. Now, the next type of radius fracture we have is an ulnar radius fracture. So whenever you fracture one of these, you often fracture the other one as well. Why? Because the interosseous membrane, right, interosseous, between the bones, the membrane between the bones, transmits the forces between these two bones. The first type of fracture is called a Monteju fracture. So you fracture it here, you're going to get, you fracture it at the arrow, you're going to get some other fractures here. So force in the mid-shaft of the ulna, you're going to fracture your radial head's going to dislocate. This guy, right, you fracture it here, you're going to get some additional fractures over here. So come up with your own mnemonic to remember this. Okay, I had a dumb one, I didn't remember it, but come up with your own mnemonic to remember this. Okay, next we have fractures of the distal radius. Okay, so fractures here don't transmit through the interosseous membrane. So we have two types of fractures. We have fractures when we fall, when we extend our wrist and we fall. Okay, and we have a fracture, we have a different type of fracture when we fall on a flexed wrist. So come up with your own mnemonic to remember these names. I can't remember mine. But Cole's fracture is part of these deformities called, is a part of a group of deformities known as the dinner fork deformity. And the dinner fork deformity is characterized by dislocation of the distal radius posteriorly, so that it looks like a dinner fork. And Cole's fractures are a really common cause of dinner fork deformities. Next, we have fracture of the scaphoid. It causes pain in the anatomical snuffbox. Why? Because it forms the floor of the anatomical snuffbox. So if you remember, I outlined that as a key point in the spaces section of this presentation. And the key complication here is avascular necrosis, because the scaphoid is supplied by retrograde blood flow. What does that actually mean? Well, if you think about the human body, right, blood travels really easily because of gravity. retrograde blood flow is working against gravity. So it's working against gravity. So you can imagine if you damage the scaphoid, it's going to become even harder to supply blood to the scaphoid. So you're going to get avascular, no blood, necrosis. Now we'll talk about inflammation. There's 3 types: bursitis, rotator cuff tendonitis, epicondylitis. Bursitis. So first of all, what is a bursa? It's pretty much a cushion to prevent bone-on-bone action, right, or bone-on-tendon action. So it's a cushion. And the thing is, if you constantly irritate it, you're going to eventually get inflammation. So here, like there's more bursa in your upper limb, but like these are the 2 main ones. One is the subacromial, so below the acromion, subacromial bursa. The other one is the olecranon bursa. This one is also commonly known as student's elbow because, like, when you study, like your elbows get irritated, right? Next, we have rotator cuff tendonitis, which is inflammation, itis of the tendon. Supraspinatus is the most commonly affected one because it travels through a very narrow space, the subacromial space. If you remember the other tendons or the other muscles of the rotator cuff, they pretty much aren't limited by any spaces. Now, once you get inflammation of this tendon, you're going to get what's called the painful arc. So it's going to be difficult to abduct your arm between 60 and 120 degrees, okay? So I'll just reiterate here that the supraspinatus abducts your arm for the first 15 degrees. But if the tendon gets inflamed, you can't abduct between 60 to 120 degrees. Why is that? Because if you imagine you're abducting your arm, right? The more you abduct the humerus, the more the space between the acromion and the humerus is going to compress. Eventually, between the angle of 60 and 120, it's going to compress on your inflamed tendon, causing pain. Next, we have epicondylitis, so inflammation of the epicondyles. I think it's a combination of inflamed tendon and inflamed periosteum. So if you remember to first sem, the periosteum is a covering of the bone. And it's caused by overuse of the associated muscles of the epicondyle. So if you inflame your lateral epicondyle, it's because you overused your extensors. If you inflame your medial epicondyle, it's because you overused your flexors. And this is how I keep it straight. Or my friend came up with the mnemonic, Latin, right? So lateral is tennis elbow. So that means golfers is the other one. Palsies. Okay, so this is a big part. So what does the word palsy actually mean? The palsy means paralysis, which pretty much means that a nerve has been affected somehow. So these are all the palsies that you need to know for the upper limb. These are the ones associated with the brachial plexus, and these are the ones that aren't associated with the brachial plexus. First, let's talk about the axillary nerve. As we know, it's very intimately associated with the surgical neck of the humerus. So if you fracture that, you're going to get damage to the axillary nerve. And to think of the symptoms, so SX stands for symptoms. So you might know that HX stands for history, SX stands for symptoms. So to think of the symptoms, we just try and remember, what does the axillary nerve innervate and where does it end? It innervates your shoulder muscles, which means you're going to get atrophy of your shoulder muscles, therefore leading to weak abduction. And because the axillary nerve ends in your shoulder area, you're going to get sensation issues over there. Musculocutaneous nerve. Damage to the musculocutaneous nerve is pretty rare because it's well cushioned. It's really protected by the muscle surrounding it. So if you remember, it travels between the biceps brachii and the brachialis. So biceps brachii and the brachialis. So it's really well protected. So it pretty much only gets damaged from a knife injury. And to think of the symptoms, just think of what muscles it innervates and where it ends up. Right, so it comes from the lateral cord, which means it must travel laterally. So it ends in the lateral forearm. Now, our first big one is the radial nerve. Now, whenever you damage your radial nerve, you're always going to see wrist drop. Why is that? Because we know the radial nerve innervates all of the extensors of the posterior compartment of the arm. So if that gets damaged, it means your extensors aren't working properly, which means your flexors are going to be stronger than your extensors. So you're going to get unopposed wrist flexion, which looks like a wrist drop. Now, you're going to get different, so that's a common symptom. No matter where you damage the radial nerve, you're going to get wrist drop. Now, the other presentations The other symptoms of radial nerve injury depend on where you injured it. So if you injure your radial nerve near the origin of the nerve, you're going to affect all the motor and all the sensation of the posterior upper limb. Okay, and that's commonly caused by Saturday night palsy, so leaning on a chair. If you damage your radial nerve in the midshaft of the humerus, you're going to lose motor and sensation of the posterior upper limb, except the triceps. And it makes sense because the triceps is above the midshaft of the humerus. Now, this is where it's a bit different. So now we're talking about the forearm. So the radial nerve actually gives off two branches in the forearm, a deep branch, as you can see over here, and a superficial branch. The deep branch is responsible for the motor, whereas the superficial branch is responsible for the sensory. So if you damage the deep branch, you're going to lose extensor functions. So you're going to get wrist drop, okay? But your arm is going to work okay. So your triceps are going to be fine. And also, your sensation is not going to be affected. So only the motor is going to be affected because the deep nerve only does motor functions. If you damage your superficial branch, okay, your sensation is going to be affected, but you're not going to get any motor issues. So what that means is if you damage your superficial sensory nerve, you're not going to get wrist drop, right? Because superficial sensory nerve only does sensation. So you're going to lose only sensation in these parts of the hand. So I'll just re-emphasize again, what portions of the hand are innervated by what nerves are really important, as you can already start to imagine. So know this well. Next, we'll talk about palsies of the median nerve, so paralysis of the median nerve. First, carpal tunnel syndrome. So flexor retinaculum compresses on the median nerve. So this is one of the branches that you need to know, the palmar cutaneous branch of the median nerve. So when you get carpal tunnel syndrome, you're going to get your Athena muscles are going to be affected, as well as your lateral lumbricals. Okay, so your Athena muscles and lateral lumbricals, because they're supplied by the median nerve. However, your sensation to the palm is not going to be affected, even though it comes from the median nerve. Why is that? Because the sensory branch of the palm, of the median nerve, comes off before the flexor retinaculum. Okay, so carpal tunnel syndrome, you're going to get wasting of Athena muscles and like difficulties using your thumb, but you're still going to have sensation in your palm. Now, the next condition is the hand of benediction. And it's primarily caused by an elbow trauma. So if you hurt your median nerve in the elbow, that means your flexors, all your flexors are going to be affected. And it's the index and middle finger that are the most affected, that you can't flex them. So you might be thinking, hang on, why can't we, so how come we can flex our pinky and our fourth finger? Well, that's because the flexor digitorum profundus has innervation from the ulnar nerve as well. So even if you damage your median nerve, your ulnar nerve can still flex these two fingers, the pinky and the fourth finger, which means hand of benediction, index and middle finger can't be flexed. So it kind of looks like this dude's hand over here. And the shared symptom is sensation loss over your lateral 3.5 fingers and nail beds. But the palm is unaffected in carpal tunnel syndrome. So again, make sure you know this image really well. Now, ulnar claw, right? It's caused by palsy of the ulnar nerve. It's pretty much the only relevant condition you need to know about for the ulnar nerve. And this is the important part. Ulnar claw is caused by lumbrical paralysis, okay? You're paralyzing the lumbricals. Now, if you remember what the lumbricals do, you'll know what ulnar claw presents as. So using my stupid action from before, right? So it flexes the metacarpals and extends the interphalangeal joints. So if your lumbricals are paralyzed, you can't flex your medial lumbricals at the metacarpophalangeal joint, and you can't extend them at the interphalangeal joint. So they end up sort of paralyzed, looking like this, okay? Looking like this dude's hand over here. And the other fingers are unaffected. Now, ulnar claw will have different symptoms will have different associated symptoms depending on where you damage your ulnar nerve. So if you damage your ulnar nerve in the forearm, you're going to get radial deviation along with ulnar claw. Now let's think about why that's the case. We know that the flexor digitorum profundus is, there should be Flexocarpi ulnaris. We know that the Flexocarpi ulnaris is innervated by the ulnar nerve. So if we damage our ulnar nerve in the forearm, our Flexocarpi ulnaris can't function. Now, let's think about the origin and insertion of the Flexocarpi ulnaris. Medial epicondyle and pisiform. If that contracts, it's going to give you ulnar deviation. So if the ulnar nerve's damaged, you can't deviate your hand. You don't have ulnar deviation, so you're going to have radial deviation, unopposed radial deviation. So it's the same mechanism as wrist drop over here. Whereas if you damage your ulnar nerve in the Guillon's canal, which is pretty much somewhere over here, right? You're not going to get radial deviation because your Flexocarpi ulnaris isn't affected. But just remember, with both of these, you get ulnar claw because both of these, the medial lumbricals are affected. And of course, you get sensation loss. So again, know this image. And this is just a table to help you separate ulnar claw and henobenediction. Ulnar claw, lateral lumbricals, henobenediction, flexors. Thumb, index, middle are normal. Thumb, fourth and fifth are normal. Okay, so we can refer to this slide later on. Now, outside of the brachial plexus, we have palsies of other palsies. Long thoracic nerve. So we know the long thoracic nerve innervates the serratus anterior. Let's think about what the serratus anterior actually does. It comes from the ribs and inserts into the medial border of the scapula. So normally in the human, it'll keep the medial border of the scapula really close to the rib cage, right? So the serratus anterior pulls the medial border of the scapula onto the rib cage. So you can imagine that if it's damaged, right, the nerve is damaged, the serratus anterior is paralyzed, it can't keep the medial border of the scapula onto the rib cage, so it's going to protrude out. Now, the final two palsies are Erb's and Klumpke's. So these are the high-yield facts. Erb's affects the upper trunk, Klumpke's affects the lower trunk. These are the key words: traumatic vaginal delivery, so childbirth. Klumpke's palsy, right, hanging from a tree. You'll see that in the question stem. Just think of Klumpke's palsy. Now, how do we know the symptoms of Erb's and Klumpke's palsy? Like C5C, we know that it affects C5C6 and C8T1. How can we use that to know what symptoms it causes? Well, to do that, you kind of have to know what nerve comes from C5C6, C8T1, right? So you might be thinking, oh, I didn't memorize, or no, I don't know which nerve which roots form the axillary nerve, right? Is it formed by C5C6, C7, or like C7, C8T1? So you don't need to memorize which nerve roots give rise to which nerves. All you need to know is the dermatomes. So again, this is the second image that you need to memorize or remember. We know Klumpke's palsy affects the lower trunk, so C8T1. If we can imagine that on our dermatomes, right, we know that this area is affected. What nerve runs in this area? Ulnar nerve. So lower trunk palsy will affect ulnar nerve, will present with ulnar nerve symptoms, aka claw hand. Erb's palsy affects C5C6. Where is that? C5C6. Okay. What nerves go there? Axillary nerve, musculocutaneous nerve. So you can imagine the symptoms there. Yeah, but just remember that. So just to reiterate, dermatomes can help you figure out what nerves are being affected. All right, so take-home points from today. Know your muscles and origins and insertions, especially for the easier ones, okay? Otherwise, remember the general area for the complex ones, because they'll help you really know the actions of muscles and also help you understand the forearm muscles, which are really annoying to do. Understand the chords of the brachial plexus, right? So I've emphasized this a lot, and how they end up as the branches. So posterior cord will give rise to the nerves that go to the posterior arm. Finally, know the dermatomes of the upper limb. So this image over here, right? So if T1, C8 is affected at the spinal cord level, you know that it will be the ulnar nerve. It's helpful for the palsies and determining what nerve is affected when sensation over a particular area is lost. And the other thing you need to know is the hand, right? Which region is responsible for which nerve, or which nerve is responsible for which region. These are my favorite resources. So YouTube, this guy's really good, Sam Webster. Noted Anatomus is good once you understand a bit more med, because he makes everything really relevant to what you learn. Ackland videos are provided by Monash, and probably heard about Anki a lot by now. Yeah, so that brings us to the end of today's presentation. Any questions? And feel free to message me on Facebook or whatever if you have any questions later on. Yep, no worries. Thanks, guys. So good luck with anatomy. Try to approach it conceptually and really take note of the origins and insertions. Great. I'll see you around. See you.